Hi, my name is Brent Haverstock. I'm a podiatrist and clinical assistant professor with the Division of Vascular Surgery and Endovascular Therapy at the University of Alabama at Birmingham. I'd like to talk to you today about the evaluation and management of diabetes-related foot complications. Diabetes is becoming a global health problem. The global burden of the disease is shifting from infectious diseases to non-communicable diseases, with chronic conditions such as heart disease, stroke, and diabetes now being the chief cause of death globally. Diabetes is certainly becoming a global crisis. In 1980, we saw approximately 109 million people worldwide with diabetes, and that number is expected to rise to 642 million by 2040. 1 in 3 adults over the age of 18 is overweight, and 1 in 10 is currently categorized as being obese. In the United States, approximately 30 million people have diabetes, 9.4% of the population. In Alabama, we sit at number 2 with 14.6% of the population having diabetes, and it's estimated in the country that by 2050, 1 in 3 individuals will have diabetes. Obesity and prediabetes are a major concern. Nearly 40% of the American population were considered obese in 2015-2016, up from 34% in 07-08. Severe obesity also went up during this same period from 5.7 to 7.7%. 84 million Americans are considered to have prediabetes, and if these folks are not treated with adequate weight loss and exercise programs, will develop diabetes within 5 years. Diabetes-related foot complications are common and costly. They're quite a complicated thing to treat once they do develop, and our goal is always prevention. Every 20 seconds somewhere in the world, a person with diabetes undergoes a leg amputation. A recent article that was published in a UK newspaper demonstrated the prevalence of diabetic foot amputations, with 120 toe amputations occurring weekly in England, up more than a quarter since 2013. The cost of diabetes is becoming a major burden economically on our healthcare system, both in direct costs of the disease management itself and indirect costs of patients with required home care or loss of time at work and productivity. $327 billion per year is spent on diabetes management, and it's thought that a third of those costs are directly related to lower extremity complications. When we look at the healthcare costs associated with diabetes-related foot complications, we see that it's a cascading process with the disease as it worsens, and then the healthcare costs increase. So somebody at risk with diabetes who has neuropathy, structural changes in the foot, have had a previous ulceration, vascular insufficiency, are treated. There's a cost associated with that. As they develop a diabetic foot ulceration, the costs substantially raise. If they go on to a healed ulceration and they're in a point of remission, they need ongoing surveillance, which is a cost associated with. If they develop a foot ulceration that goes on to an infection, the costs again escalate, and finally to limb loss. When we look at the costs of diabetes and diabetic foot complications related to cancers, we see that the cost is now outpacing the treatment of many common cancers. With regards to what causes diabetes-related foot complications, neuropathy is probably the most common, and it's considered that 60 to 70% of individuals with diabetes develop peripheral neuropathy or loss of protective sensation in the feet. Over their natural history, 34% of individuals will develop a diabetic foot ulceration, and we've seen a steady climb in that number over the past several years. 20% of moderate or severe diabetic foot infections will lead to some level of amputation, whether that's a localized amputation within the foot or requiring a more major proximal amputation such as a below-knee or above-knee amputation. The mortality associated with lower limb loss is quite staggering. When we compare it to many of the cancers, we can see that the 5-year mortality rate after limb amputation is 68%. This is second only compared to lung cancer at 86%. So there's a much better survival rate associated with colorectal cancer, breast cancer, Hodgkin's disease, and prostate cancer. When we look at the mortality associated with ulceration, a study that was completed at King's College Hospital Foot Clinic in the UK looked at 234 individuals with a diabetic foot ulceration who had died. In postmortem examination, they determined that ischemic heart disease was the major cause of death in 62% of these individuals. This has really signified that there needs to be a much more intense evaluation of the patient overall from their medical status once they do develop an ulceration of the foot. It's often considered that this ulceration is a mirror to what's going on pathophysiologically within the body, and we really need to look at cardiac profile and really start to intensify overall medical management. Mortality, again with ulceration, another large study that was done in the United Kingdom with over 400,000 individuals enrolled in a health improvement network, with 20,000 individuals that presented with a first-time diabetic foot ulceration. 5% of these individuals had died within 12 months of their first visit for this ulcer, and within 5 years, 42% of these individuals had died. Again, the diabetic foot ulcer is not the direct cause of death, but it certainly demonstrates that there's a much greater need to have a closer look at the cardiovascular history of these folks and really do a significant workup, as well as working on their overall medical management with weight loss, greater control of their blood sugar levels. Again, now when we look at the relative mortality associated with diabetic foot ulceration, peripheral vascular disease, and limb amputation, we can see from this chart that it's becoming much more of a problem even than cancer this day and age. So what is the cause of a diabetic foot ulceration? There's a number of factors. Local systemic contributions include uncontrolled hyperglycemia. Hemoglobin A1C levels over 7 are certainly a marker for the risk of developing an ulceration. Peripheral vascular disease, duration of the diabetes, blindness, chronic renal disease. Again, all these problems that demonstrate that there's a much greater medical concern for the patient often result in this ulceration. When we look at local issues, peripheral neuropathy, that loss of sensation in the feet, an individual steps on a sewing needle, or they develop a corner callus on the bottom of the foot that they don't identify as being painful, that goes on to breaking down and resulting in an ulceration. Structural deformity or changes in the structure of the foot result in areas of increased pressure. And we can see on this slide here that the ulceration is developed underneath of the second metatarsal head, which is prominent. This is calloused over time. That unrecognized callus, because of the lack of pain on the bottom of the foot, results in an ulceration due to a bullous formation. The callus naturally sloughs off, leaving open this direct lesion, which is full thickness in nature. Other complications include ankle equinus. Over time, the Achilles tendon will shorten up due to cross-linking of the collagen in the tendon. That tightens up the calf muscle and Achilles tendon. This subsequently results in more pressure on the forefoot as we're walking, and again overloads the area, resulting in repetitive stress and trauma to the skin and soft tissue. Peripheral vascular disease is mixed into this, which I'll talk about in a minute. When we look at the cascading events that result in an ulceration, we can see that the peripheral neuropathy, resulting in that lack of sensation in the bottom of the foot, the structural changes to the foot, and autonomic neuropathy, which results in dryness and changes to the skin, loss of tuger and texture of the skin. We see on the first or top diagram of the foot the callus formation that has developed on the ball of the foot under the first metatarsal head. As this progresses with a lack of identification of the pain, we see a bullous formation that has developed underneath with hemorrhagic changes and bleeding underneath of that callus, and over time that will slough off, leading to a full open ulceration on the plantar aspect of the foot. Again, with a tight Achilles tendon, we see an early heel lift. That results in prolonged pressure on the ball of the foot. So here on the left on this diagram, we can see the tight Achilles tendon resulting in high stress pressure underneath of the ball of the foot, compared to a normal, where we see a normal glide and load of a heel strike and a toe off. On the tight side, we see where the heel lift is much quicker in the gait cycle, resulting in prolonged pressure on the ball of the foot. And here we can see the ulcerations that are formed in a classic position in an individual with what we call a gastrosoleus equinus. To test for that in the office, when you have the patient on the examination table, you put their knee into an extended position, bring their foot into a neutral position, and then we check for the amount of dorsiflexion that's available at the ankle. Normally it should be greater than 10 degrees from neutral. Here on this diagram we can see that the patient is probably sitting at approximately 10 to 15 degrees of plantar flexion. We can then check that with the knee flex. That'll relax the gastroc, which has an origin above the knee, and if the soleus is tight, then we'll have the same sort of findings. If it's strictly due to a tight gastroc, we'll see the ankle joint dorsiflexion go to its normal amount of 10 degrees. So again, these changes in pressure points on the bottom of the foot result in the callus formation and subsequent ulceration. So here we can see the normal distribution of the gait cycle on the slide, where we strike on the outside of the heel, we start to load across the ball of the foot, and we project out our great toe. On the diagram with the ulceration demonstrated on the great toe and underneath of the area of the second metatarsal head, we can see how that corresponds with the peak pressures on this pressure mapping, where we see the elevated pressures underneath of the second metatarsal head as well as the great toe. So here's a clinical example of what we call a forefoot valgus. When we load the foot into a neutral position, subtalar joint neutral, and load the forefoot, we can see how the first metatarsal underneath of the great toe is sitting in a lower plane. So when we're walking, that area is projected to receive more pressure. We can see callus formation develop under the first metatarsal head. Again, with the neuropathy and the lack of identification of the pain due to the thickness of that callus, it results in tissue breakdown, which we see on the slide beneath. When we look at the coexistence of peripheral vascular disease with these patients, we've seen a shift over the last 20 years. We used to see that the majority of folks that came in with an ulceration on the plantar aspect of their foot really had normal circulation to the feet, but it was that loss of the normal sensation which resulted in this ulceration. We've seen a big shift in these numbers over the past several years, where now only 35% of these individuals that present with an ulceration are strictly neuropathic and have normal findings on their vascular examination. Approximately 15% are purely ischemic in nature, so they have severe critical limb ischemia, which has resulted in an ulceration or tissue loss. And the majority of these, approximately 50% of our patients that present with an ulceration, are what we categorize as neuroischemic, so they have a combination of the neuropathy as well as the ischemia, which really needs to be identified if we're going to treat these individuals properly and hope to heal this wound. So again, over 65% of diabetic foot ulcers are associated with a degree of peripheral arterial disease. So when we look at our vascular examination, we want to start with our basics, a history and physical examination of rest pain, claudication when they're walking. With regards to our examination of the patient themselves, we want to palpate the pulses. We can start high up with the femoral pulse, work our way down to the popliteal, the posterior tibial artery, and the dorsalis pedis. This will help us to determine where the level of blockage may be. If an individual has a palpable femoral artery, but the popliteal artery is non-palpable, then the occlusion is somewhere in between the two. If they're palpable, the femoral, the popliteal, and we get down to the foot, we'll find that the blockage is normally somewhere between the knee and the foot, which is the most common presentation in these patients that we see. We also want to look for signs of loss of sensation. So are there atrophic changes to the skin? Is the skin of the toe starting to become shiny and thin in nature? Digital hair loss or digital growth, often in these folks where the trifurcation of the arteries below the knee, that's where we see hair growth stop, and the rest of the lower leg and foot will be void of any hair growth. We also want to check for dependent rubor and elevation pallor. When the patient's foot is on the ground in that gravity-dependent position, is it becoming bright red? If it's elevated above heart level for a few minutes, does it stay red or have a nice pink color to it, or does it become white, indicating that there's not enough force for blood flow to get into the foot, so the tissues are starting to blanch and become white? Non-invasive vascular studies can be helpful. ABIs, looking at ankle-brachial index. One of the problems that we see today with our diabetic population is that over 60% of individuals with long-standing diabetes that present with an ulceration have now developed some calcification within the blood vessels. This can lead to some false readings on the arteriobrachial index, which can be problematic when we're trying to determine whether these folks will heal properly or not. We can look at waveforms, and we can also use transcutaneous pressure measurements as demonstrated on the foot here, where we're looking at the levels of oxygenation that reach the skin with a test that's done by our technologists. Here again we can see the x-ray on the left of the foot, and we can see the calcified vessels, both the posterior tibial and the dorsalis pedis. And then we can see here on the ankle brachial examination the falsely elevated pressures, and we can see how the toe pressures are starting to diminish as we get distal into the foot. So when in doubt, consult your vascular surgeon. The rule of thumb that I've always had with these individuals is if I can't feel pulses in the feet, that raises a red flag, and I'm really concerned even if I do a debridement of the foot and I see active bleeding around the ulceration site. The question is there adequate oxygenation and nutrients being delivered to that site for it to actually heal? If we think that if we actually debrided an ulcer and it was void of any blood or bleeding at all, then we'd have absolute ischemic changes to the extremity, and that would be a precursor to significant gangrenous changes. So don't be fooled by the fact that there may be some bleeding around the ulceration to think that this is going to heal. So if you do have any questions, consult your vascular colleagues immediately. The management of diabetes foot complications can be quite varied. If we follow standard protocols, we let the body heal itself. Often we just need to do some things to change it so that the body will heal. And in cases where the body is rejecting some of these, there are some things that we can try to adjunct with that healing process. With diabetic foot ulceration, we want to obtain infection control. We want to debride the ulcer adequately of all non-viable tissue and callus around the margins, which will continue to increase pressure to the tissues and result in soft tissue breakdown. We want to provide adequate offloading of that ulceration. We need to get any pressure off of it. And again, if there's any questions of the circulation to the foot or the extremity, we want to consult our vascular colleagues to see if there's any intervention that's required to increase that blood flow and healing capacity down to the foot. Debridement is essential. We need to remove all non-viable necrotic tissue from the wound bed, get it down to a nice, healthy bleeding base. We want to obtain some bleeding by even cutting away some of the healthy granulation tissue. When the platelets enter the area to help clot off the wound, they release growth factors, which are very important in the development of granulation tissue. So we really need to be quite aggressive with removing all this non-viable tissue and creating a bleeding network within the wound bed itself. When we talk about offloading, the total contact cast is still the gold standard. It's used quite readily at our institution for getting the pressure off of these folks. They can still ambulate, but the function of the cast itself with the pistoning down the leg offloads the area, and also the felt modifications that they utilize within the cast will redistribute the pressure around the wound and take it off of the ulceration. Here we can see the pressure mapping again of the foot and see the high concentration underneath of the ball of the foot over towards the great toe. And as they're put into that contact cast, we can see how that offloads and redistributes the pressure more evenly around the foot, removing that pressure load from the ulceration site itself, which is paramount in allowing for proper healing. There's a number of different offloading devices that are also available. Compliance with total contact cast can be an issue for some folks. Some individuals are claustrophobic and won't tolerate a cast. So there are different types of walking shoes. We can see in the top left-hand corner a wedge shoe that will offload the forefoot. The shoe adjacent to it has an offloading component for the heel. The air casts come with different devices. Some have actual insoles in them with hexagon plugs that you can remove around the area of the ulcer, or you can have a prosthetic or orthotist make an insole for inside of a removable walking cast to offload that pressure. The example on the bottom left is a Charcot walking cast or a crow walker, and we can see here on the picture to the right an ulceration on the plantar aspect of the foot secondary to a Charcot foot with a rocker bottom deformity, and this crow walker is a very good device for offloading the pressure. It's almost like a removable total contact cast. Diabetic foot infection. We really look at these in two broad classifications. Is the diabetic foot infection in an ulceration, is it mild to moderate? Is there the presence of mild drainage? Is there some erythema around the ulceration, some pain? Again, these individuals are neuropathic, typically won't see pain with a problem within the foot. So if we do have an infection, that often really should raise a red flag because of the pain, lack of pain normally in the foot. So an infection can cause some pain. With the mild to moderate infection, again, a history. Have they had any fevers, chills, night sweats? Have they felt unwell? We like to classify that as a diabetic foot flu, and we often tell our patients that we see in clinic to really watch for signs of really what is flu-like symptoms, which can actually be an infection starting in the foot. They start to feel unwell, a loss of appetite. They just lost some of their overall strength. They just feel unwell, and they think it's the flu, and not until they present to the emergency department a couple days later because they're worsening that they actually remove a shoe and sock and find that it's an infection in the foot, which has resulted in this diabetic foot flu. We look at labs. We access the need for inpatient management. Typically in the mild to moderate infection, this can be treated based on previous microbiology data that we may have on record. We select initial empiric antibiotic therapy, an oral antibiotic. We get them into pressure loading, offloading, and proper dressing. And if they're not hospitalized, arrangement should be made for them to be seen in a follow-up clinic within 24 to 48 hours to make sure that this is not worsened and does require hospitalization. In a severe infection, this is a medical emergency. Time does equal tissue. We want to decompress the area. The longer that this infection is undrained, the greater tissue loss we see, the more death of tissue, which then necessitates a more proximal amputation. So the quicker that we can see these patients and get them to the operating room to drain these infected abscesses, we see much better outcomes. So again, our history and assessment, we want to review labs. Do they have an elevated white blood count? If it is elevated, again, that certainly is a marker that this is a medical emergency. We want to review simple x-rays. Do we see any signs of soft tissue gas or air within the tissue? The patient has started on a broad spectrum antibiotic, and the surgical service is consulted for really an immediate incision and drainage, and I feel that a patient should be in the operating room within 6 hours of presenting to an emergency department within the hospital. Here's a case of a 28-year-old female that presented to our institution. She was 8 weeks pregnant. She had an ulceration underneath of the fourth metatarsal head. This resulted in a deep space infection, which is an emergency. We can see the changes in the color of the skin tracking around from the ulceration on the bottom of the foot in through the arch area. We can see the swelling within the foot. And again, this needs to be evacuated immediately. Here we can see the foot has been opened up with an incision and drainage to really drain all the pus from the area, irrigate it, and then take proper deep soft tissue cultures. The MRI demonstrates changes. You can see the ulceration underneath of the fourth metatarsal head and the changes within the fourth metatarsal head, which were consistent with osteomyelitis. A bone biopsy was taken at the time of the procedure, which was positive for osteomyelitis, which will help our infectious disease colleagues tailor the antibiotic therapy for that infection as opposed to broad spectrum antibiotic therapy. This is the patient seen in follow-up. When we look at another complication with these types of wounds, a bone infection or osteomyelitis is a very controversial subject with regards to how to treat it and the proper use of diagnostic imaging. Osteomyelitis is an infectious process within the bone. A patient with a soft tissue infection or skin ulceration for greater than 1 week is already at risk of a bone infection developing. This is a continuous source of infection from the ulceration down to the bone. Acute diabetic foot osteomyelitis is direct bacterial inoculation through the ulceration into the bone. Bacterial proliferation results within the bone itself. This induces an acute bone response in the medullary cavity. This leads to increased intermedullary pressure and congestion within the bone. Left untreated, this results in disruption of the interosseous and periosseal blood supply, which results in osteonecrosis. On this slide, we can see the image of the foot with the ulceration over the medial aspect of the great toe, and the corresponding x-ray demonstrates the changes that have occurred to the bone as the bone has become lytic due to that congestion and loss of blood supply resulting in the osteonecrosis of the bone. So when we're looking at the foot with an ulceration and determining is there an underlying bone infection, We want to see first, does that wound actually probe down to the bone? We can take a sterile steel instrument, pass it through the ulceration, and see if we can touch the underlying bone. Studies have suggested that this has a 90% probability of an underlying osteomyelitis if the wound does probe down to the bone. Radiographs are taken. It generally takes 21 days before we start to see changes on the x-ray as we see the loss of the bone itself. It really takes 30 to 40% of bone density loss before it becomes visual on an x-ray. In my hands, if I have a bone that I suspect is being infected and it does probe through the ulceration down to the bone, and I take an x-ray and I see any changes on the x-ray that are consistent with a bone infection, I don't carry on with any further imaging. I think at that point in time it's imperative to get an adequate bone sample, both from a pathological standpoint to see if there's pathological changes consistent with osteomyelitis, and to get a sample for infectious disease with regards to culture and sensitivity of that bone, and also a deep soft tissue culture if we were to see a case where the pathological evaluation demonstrated that there was osteomyelitis, but we weren't able to obtain any growth within the bone itself on the culture. If we had a positive soft tissue culture, then infectious disease would typically treat that bone infection as being the same organism that was found in the soft tissue. If I question whether a bone is infected still based on the fact of its clinical presentation and I haven't seen any changes on the x-ray, then I would consider either a white cell labeled scan or an MRI. But again, a bone biopsy is our gold standard for determining a diagnosis of osteomyelitis and helping to drive the appropriate antibiotic therapy. So again, with our treatment, the standard approach has been surgical resection of infected bone and the use of antibiotics. We want to try to preserve, with the case of the foot, as much of the structure as possible. So we are trying to limit some of this resection of bone and minimize tissue loss. So we want to get the adequate bone biopsy so we can start the therapy and then tailor it accordingly, and also work with local wound care and see how much of the foot we can save. If we fail and have to go back and do a more proximal amputation on the foot, we will, but we often try with whatever we can do to spare as much length of the foot as possible. One of the biggest problems with osteomyelitis is really the time duration of therapy, and this is something that's controversial and often being researched as to how long one should be on IV, and then oral antibiotics, or now we're finding our oral antibiotics alone adequate for treatment of some of the less complicated type of infections, but there is a high recurrence rate of 20 to 50% of these. So we really need to think then about the length of treatment for these, and there needs to be much more work done on research with regards to this. Again, if we look at aggressive bone resection, this leads to deformity, which could be really problematic when it comes to shoe fitting, recurrence of other ulcerations in other parts of the foot, and often these folks would often be better to have a baloney amputation and a good prosthetic fitted, as opposed to the structural changes that we see that are very difficult to shoe. So again, recently, uncomplicated forefoot osteomyelitis, a single metatarsal that's infected. Once we obtain adequate bone cultures to drive the antibiotic therapy, it's been suggested that 6 weeks of oral antibiotics now are as predictive as an outcome with regards to eradication of the infection as IV antibiotics. So here we can see a case of a neuropathic ulceration on the plantar aspect of the foot. The things I would keep in mind with this is that the foot itself is not infected with regards to soft tissue infection. We don't see any active purulent drainage from this ulceration, but it is contiguous down to bone. We take an x-ray, and here we can see the destructive changes which have occurred to the second metatarsal and over even towards the third metatarsal, as well as the soft tissue swelling. At this point in time, I wouldn't recommend any further imaging is needed. Really, at this point in time, we need to get adequate bone resection, remove that second metatarsal head. We can see how lytic it is. We remove that bone, send it for culture and sensitivity, start our normal approach to the treatment of this patient with offloading, weekly debridement of the wound, and their IV antibiotic therapy, checking for their vascular status. Do they need any vascular workup or vascular intervention? And this type of foot ulceration, we should be able to get into remission and healed. Preventative care is the key to stopping all of these. A patient should see a professional on a regular basis. They should see their podiatric physician in the community to have their feet assessed on a regular basis, have their toenails properly cut, any corns or calluses addressed, sent for proper fitting shoes, work with their family physicians or other medical specialists to make sure that their overall diabetes management is optimized, and hopefully we can prevent these complications from occurring. Again, in the outpatient environment, we want to check their vascular status, their neurological status, tendon reflexes, using a monofilament to check for the sensation on the bottom of their foot, a dermatological examination, the toenails, the skin itself, dryness of the skin with autonomic neuropathy, getting patients to hydrate their feet properly with a lotion. The lotion isn't really the key itself. There's so many different foot lotions that are available out there. The key is making sure that that patient is getting that cream on their foot once or twice a day, and making sure that they minimize how much they put in between the toes. Prophylactic foot care, education, stressing to the patients the things that they need to do themselves at home, like inspecting their feet, watching for those signs of diabetic flu, and then sending the patient off to a proper foot store or footwear shop where they can be fitted properly and fitted with shoes that aren't going to have any pressure areas. Loss of limb reduces the quality of an individual's life, changes their functional status, and results in a loss of independence. We've also seen that once one limb is amputated, the second limb, within 3 to 5 years, the limb loss is usually over 50%. At the University of Alabama at Birmingham, we have developed an advanced limb preservation program with a clinic and an inpatient service. Our goal is amputation prevention. We've utilized what we call the toe and flow model, with podiatry and vascular surgery really being the two endpoints of the service, and then we bring in all the other consultants as deemed necessary. We work very closely with infectious disease with regards to the appropriate antibiotic therapy. We work with plastic surgery if there's any soft tissue coverage that needs to be considered. Our orthopedic colleagues are great at UAB with regards to Charcot reconstruction. Our general surgeons will often help with some of the debridements. And then overall with our internists, endocrinologists, cardiologists, nephrologists, really maximizing the patient's overall health. And then our podorthists that we have at the Spain Rehab Center in the orthotic and prosthetic department can help us with proper shoe fitting and protective insoles within the shoes.